Hello, this is the video presentation on cardiac arrest and CPR, determining which training increases survival rates by Sarah Albright Alfano, Wajdi Bader, and Jennifer Penson for MPH 606 Methods of Research in Public Health. So we'll start off with what we already know about sudden cardiac arrest. According to the 2019 heart disease and stroke statistics provided by the American Heart Association, the incidence of in-hospital cardiac arrest, otherwise known as IHCA, is about 209,000 people annually, while the incidence of out-of-hospital cardiac arrest is more than 347,000 people annually. Most out-of-hospital cardiac arrests occur in private residences, followed by public settings and nursing homes. Of course, EMS response rate varies across geographical areas of the country, making bystander CPR and AED use, which is automatic external defibrillator use, crucial for increasing survival rates during out-of-hospital cardiac arrests. It has been shown that those who receive training in CPR and AED use, who witness an out-of-hospital cardiac arrest, are more likely to perform CPR and AED use, and thus it is more likely that the person who had the cardiac arrest is likely to survive with a favorable neurological outcome. Now, as far as CPR and AED use itself, we already mentioned that bystanders are more likely to use AEDs when they already know how to use them, but also when they're more accessible. So, in order for AED use to be effective, they have to be widely available and accessible to the general public. When they are used, AEDs can triple a person's chance of survival from cardiac arrest. Of course, to be most effective, CPR training has to be recent and have included hands-on training with mannequins. When this training has occurred, initiation of CPR is much more likely to happen by the bystander. Now, as far as dispatcher-assisted training, what we mean by that is when a bystander calls in to 911 and they receive instructions on how to start and perform CPR and potentially AED use on a person who went through cardiac arrest. Recently, the AHA has recommended compression-only treatment, as it has been shown to increase the chances of CPR in out-of-hospital cardiac arrests. The use of dispatcher-assisted CPR is low cost and highly effective, and its use in general is associated with a greater chance of bystanders performing CPR prior to the arrival of EMS. It has its limitations, however, as sometimes dispatchers have difficulty recognizing a cardiac arrest via the phone description, and therefore can miss the opportunity to properly instruct the caller on CPR and AED use. So, what we want to know through our study is that whether it is better for a population to have CPR training biennially, which is every 2 years as recommended by AHA, or is it better to have on-the-spot training, if you will, via dispatch instructions for all out-of-hospital cardiac arrests? Our study aims to find the most efficient and successful way for increasing the incidence of bystander CPR performance in case of outside of hospital cardiac arrest, and therefore increasing survival rates and improving survival rates with good neurological outcomes. We will be comparing two groups, ones who have went through hands-on training versus ones who perform CPR with instructions via dispatch. The outcomes we will be looking for are restoration of spontaneous circulation, 1-year mortality rates, and 1-year mortality rates with favorable neurological outcomes. The participants of our study will be those who have witnessed an out-of-hospital cardiac arrest and were active participants in performing CPR and or EAD use. We will use cluster sampling. Given that the US population is about 220 million people and about 350,000 outside of hospital cardiac arrests occur annually, we would estimate we would need a sample size of at least 36. Study participants will be interviewed with both qualitative and quantitative questions in an attempt to gather information comparing the two groups. We have selected a retrospective cohort study, as is an affordable way to measure in an already created population with standardized best practice data. This is again going through the fact that we will be using cluster sampling on large urban areas. We will be focusing our questions on formal training or whether the person had instructions during CPR. Data collection plan. We would continue performing the study until we get the sample size required. We will perform one-on-one interviews with those bystanders who witness a cardiac arrest and utilize CPR and or AED use within the past 12 months. The quantitative data will gather the factual information regarding the incident. Questions will include, but not limited to, demographic information, any prior training, any physical or mental limitations to performing the CPR. As for qualitative data, we will prefer semi-structured interviews with open-ended questions in a predetermined order to eliminate influencing the participants, bias from the interviewer. In addition to that, having qualitative data that is easy to compare to other participants. Qualitative questions we can ask. Thoughts about performing CPR on a stranger versus ones who perform CPR on family members or friends. Discussions of what prevented CPR or AED use, if any. Knowledge of need for CPR or AED use. Ethical considerations. We don't foresee any risk to the participants themselves, given that this is a retrospective cohort study. The data we will be pulling from cardiac arrest registries in regards to survival rates is retrospective. We are not intervening on any patients or persons. As for anonymity, we will use numbers to identify the participants so as to hide their identity. We will randomize them through numbers 1 through 36, our sample size. We will use secure data storage registries and be sure to shred any paper documents after entering this information into our database. Informed consent will be provided, written and verbal. The research assistant who is conducting the interview will review this document with all participants prior to their completion of the interview. Participants will have the opportunity to review the document and ask any key questions they have in regards to their participation prior to agreeing or declining in participation in the study. As for incentives, we think a gift card of some sort for those willing to participate would suffice, given that it would keeping the persons anonymous and would be easily distributable. For those who uh, don't care about being anonymous, we can have an honoring plaque or information on a website registering their participation in our study, of course, with their consent. As for logistics, the qualifications for the research assistant would include clear communication skills, ability to record and possibly transcribe their interviews. Basic computer skills, such as Word and Excel, would be needed. Use of PubMed, Google Scholar, Cochrane, and others for literature search. Level of familiarity with the process of having BLS or having a certificate in BLS would also be important. These are our references for the study. Thank you very much for listening to our presentation.